Okay, right. So by one of my clocks, I make it 12:05. So let's make a start. Thank you very much for joining. It's amazing to have so many people at such short notice. The key aim of this event is mainly because I was pretty keen that everyone else in the UK, and I am trying to make this as English, Scottish, Welsh, and Northern Irish as much as I possibly can, was as up to speed of things that they can be doing in their ED/assessment units. This isn't an official workshop by any particular organization, so it's not kind of led by the RCPCH. I've been involved and discussing with Jane Bayriver of APEM for some time, and we are hoping to do an APEM type event, which may well follow from some of the questions or things that we can't resolve in this particular session. I'm personally, I suppose, a little concerned that from a national level and even on a local level, that the message of the real strain that the children's emergency care system is under hasn't been completely recognised, and I get that from virtually every kind of conversation that I have with people with inside my department and outside my department. That's not to say that other parts of the system aren't at breaking point either. I know my adult colleagues are facing similar battles, and I know the whole paediatric system is in a lot of difficulty. But I think there is a specific need for better awareness of the challenges specifically for paediatric emergency care. And hopefully I'm going to share some slides which demonstrate that. So I'll have a little talk just from me. I've got a few people who are then going to say a few words, but the critical thing from my point of view is getting a discussion going throughout the group of people who are here, and be able to pick up and share some of the resources that I know exist, but make sure people have access to those as much as possible. So hopefully, I think the slide has moved on. Please just stick in the chat if you're not able to see the slides at the moment. Winter has arrived, may even get even worse. And this is a really unusual year. Because of what happened last year, it's really difficult to know where we are in the natural seasonal state of play. And here is a graph that is taken from my own department, at the Leicester Children's Emergency Department. And we have basically a potential trajectory. So we filled in what we think might happen in October, November, December. And I think you can see that that will give us the largest numbers that we've ever seen. We were at about 60,000 per year. We may well get up to 70,000 a year. And I think that graph is similar to most departments in the country. And I will get up towards some evidence for that shortly. But there is an argument, and when I've shown this graph to people, they go, well, kind of, is it modeled? We really don't know what's going to happen in October, November, because maybe the RSV surge has been and gone already. So here's some slightly kind of stronger data, and this is using modeling. So what you can see from the shaded or hashed bars is that's what would have happened had COVID not occurred. So that the numbers with 256 and 269 are what we would have predicted to have seen if COVID hadn't have happened. Now you can see from the grey bar that clearly 2020 was an extremely quiet year for us, but already we've gone above what you would have naturally have projected from what should have happened without COVID. And that's where a lot of cause for concern comes in, because this means that either illnesses are getting more virulent, or that the public are demanding more emergency care. And I think it's probably a combination of both of those. And clearly, if I just make this scroll in a bit, what you can see is that in Leicester, we are already about 30 patients a day above what we would have expected to be seeing. and that if that trend continues into November, we will basically every day, because these are average numbers, see over 300 children a day. Now that's a large amount, and we're clearly not modelled for that. But to really make the point about this just isn't a Leicester effect. So what the heads of service WhatsApp group have been doing is bringing together data. So this is data from 20 children's emergency departments, both relatively small and relatively large departments. So I think it goes across the whole spectra of departments. And you can see basically the data is all saying the same thing, is that the trend June, August, September, October has been exactly the same, barring 2020. And that this year is significantly above, and the exact number is 16.2%. So that's the average increase in attendances between 2019 and 2021. And there's a couple of things that we can do at this point. We can go, well, actually, okay, maybe this year will be different, and that we won't see an increase in October, November, and December, and this is the peak, and things will get better from now. Or we can go, well, we're likely to follow that same trajectory. And I'd like to be in a position where at least I'm aware as possible as what might happen in November. And what I'm very happy to do is after this seminar, share this graph and share some of the data behind it. And we will be taking, as the ED heads of service groups, some of this information to the RCPCH. One of the other questions that gets asked a lot is about what is happening with RSV. So as I'm sure you're all aware, last year we saw very little of it, and then across the world, when people came out of kind of social distancing and isolation, RSV came back. We have had peaks across England, and we have seen those peaks start to subside. The only places where it hasn't happened is actually in the East Midlands, where we've plateaued a bit, but certainly I think the north east saw quite a big spike, and that's come down. Now, I apologize, this isn't my particular slide. I've borrowed this because I only received this data this morning, but this is looking at expected burden, and I'm showing you this slide because it's important to understand what may or may not happen. So as you can see, in the age group 5 to 19, we're actually seeing the same amount of RSV positivity in that group that we have done over the last couple of years. In fact, compared to the last couple of years, we have seen, compared to the mean, slightly less in the 0 to 1 age group, but you can see that red dot. We've massively seen more RSV in the 1 to 4 age group. Now, this tells us one of two things. Either that we have seen the bulk of RSV, our surge has come to an end, and the reason that we've seen a lot of cases is because lots of children who were 1 to 2 who didn't get RSV last year have got it, or that actually what we've seen over the last couple of months is that 1 to 4 group who have got RSV, even if we weren't testing for it, and even if they didn't look like it, and we've still got a peak to come. And I think even the modelers don't know if that's the case. This graph gives me the most concern. And so what we can see here is a graph of hospitalizations. And I think the obvious point is ignore the blue and green lines, because I think they're a bit confusing. But the black line is hospitalization rate from the units that submitted data towards this, compared to data from 2018 and 19. And you can see our hospitalization rate is slightly lower. Now, my reading of this is that while we have seen RSV emerge earlier, it may well be yet that we haven't seen our normal winter spike come. And that's why I'm so nervous about what this November might bring. Please do, if you've got questions about this, if I'm going too fast, etc., stick it in the chat and I will pick that up. So what I really wanted to kind of highlight to everyone, and this is a system that we've adopted as part of our SOPs in Leicester, is to think about crowding as a result of staffing, inflow, outflow, and acuity. So staffing's self-evident. If you have not enough staff for the patients you've got in your department, then it becomes difficult to see those patients in a timely fashion, and both assessment blows out because you've not got enough nurses at the front door, and waiting times for clinical review blow out because you've not got enough clinical staff to see them. Staffing is often, though, outside of our control. You've got the numbers of staff you've got on your shift or not. Now, there's discussion we could have about where extra staff are going to come from, but staffing is really challenging, and I've got no easy answers for you. Then there's the impact of inflow. So certainly this year, that inflow has been ridiculous. We sometimes have had 20, 30 patients arrive an hour. And then you combine that with outflow, i.e. you're not discharging patients quick enough because they've physically not been seen, or you're not getting them to the ward because the ward are also full with all the staffing and other problems that we've got. And then you add in high acuity, which, to be honest, I know we've been seeing sick patients, but I personally don't think we've seen the sickest patients of this winter. So you add in acuity, inflow, outflow, and problems with staffing, and then the end result is crowding. Now, apologies if this is self-evident to you, but I show it like this because I think this is a useful slide. If you've not encapsulated your own processes in this way, this is good to take forward to demonstrate to others outside the ED some of the challenges that you might face. Then the other way of looking at the problem, and this is where I want to spend a bit of time kind of talking and discussing and sharing ideas, is breaking the department down into facets. So I'll just move through this quickly. So let's think about pre-hospital. So what is the effect of children outside of your hospital having on your ED? So clearly the major talking point of the last couple of months has been access to primary care. Personally, and I think the data supports this, is that primary care are overwhelmed in exactly the way that we are, and we're seeing that leach of patients who can't get into their GP practice, so they just come to the ED. Locally in Leicester, what we found is that the majority of GPs are doing face-to-face appointments, but there are a small group of practices which aren't, and those practices are disproportionately represented in our attendance data. And so we are working with the commissioners to sort that out, to try and get those practices to see face-to-face again. So again, and apologies if I'm teaching you to suck eggs, but if you've not looked at your GP practice codes for patients who are presenting to your department to find out if there are particular practices or areas in your locality that are overrepresented in admissions, I suggest you do that, because then you might be able to target interventions. The other thing is about communications generally. I've been throwing my toys out the pram for quite a long time about the absence of national communication about some of the difficulties that we face, but also at a local level. Now, I've had some very interesting discussions with both commissioners and regional comms leads. And to be fair to them, that they have provided me with some kind of pretty robust evidence, actually, about why some of the communication strategies don't work as well as we think that they would do. And I don't know if there's anyone from Nottingham on the call to corroborate this, but my understanding is that Nottingham went through a period of time where they were actively advertising how busy their emergency department was, were recommended that kind of families looked elsewhere. And what they found was an increase in attendances to the emergency departments in the 3 to 4 days post those announcements. And there is evidence to back up that these comms can go badly. And I think one of the best examples of that is the fuel crisis that we've just had. Is people seem interested when there's a crisis. So I don't think communications is as much of a solution that I would have hoped for. Assessment. So I think most people try to work towards the intercollegiate document, which suggests that children should have a full assessment, and that I mean a set of observations where that would be appropriate within 15 minutes of arrival. And this is something that has been a huge challenge in Leicester, and something that we have really struggled to meet. And it's mainly because if your inflow is massive and you've only got 1 to 2 assessment nurses, it's virtually impossible to meet that target. Now, there are things that we might be able to do to help that, and that's one of the things that I would like to discuss on this session. But often we get asked about redirection or kind of deflection from the front door. And I think units that are able to do that, it would be good to hear those voices. But we've really struggled with that in Leicester. It's very difficult once a family has arrived, have taken a long bus journey to get to us, or whatever they've done, or they've paid for their parking, to turn them away, to send them somewhere else unless there's somewhere to go to. So that does make assessment a challenge. Sorry, my computer's just telling me it's about to turn off. That's a bit embarrassing. Let's just save the day and make sure that I don't run out of power. Okay, let's come in. Right, saved. Sorry, embarrassing. Right, so majors and illnesses. The talking points there is what can we do within our own departments to improve things. The big message here, I think, is about infection prevention. And one of the things I really wanted to highlight was what you can do with your infection prevention teams. I've heard a lot of feedback that IP have really been crystal clear about separating waiting rooms, about socially distanced beds. But it is possible with well-written risk registers to come to some form of compromise with IP, and that is certainly something that we have done in Leicester. And again, I'd be willing to share those reports. It's not easy, and it does take a bit of time. But one of, I think, of the asks of bigger organisations is and by bigger organisations, I mean kind of the colleges, whether RChem or RCPCHs, is to have some better guidance on IP. I know we have to prevent the spread of RSV and COVID, but we can't do that at the detriment to the functioning of our departments. Minors and injuries. So sometimes these are seen as quick wins. We had a really good discussion as part of the heads of service group, because I've made a suggestion is, could we move injuries to other localities? Could there be other UTCs, minor injury clinics, that see injuries at the risk of, at the expense of the ED not seeing them? So we just don't see injuries anymore. And I think that the feedback from that was, well, actually, Damien, I think these are low-hanging fruit. They are patients we can see quickly. We are the experts in this, and this is something that we should hang on to. But again, it'd be interesting to have thoughts on that. And then is the use of primary urgent care, either within your emergency department, so having GPs who see a primary care stream, or having an urgent care centre co-located to your department, so those patients are just sent there, or at a completely external location. Now, one of the problems that we've had with that locally is one is the GPs who come tend to be locum GPs, that sometimes their experience with pediatrics isn't that great, and that you get some amazing GPs who are absolutely brilliant at seeing children, and then some who maybe struggle a bit more, who ask more questions, and then the flow for that line particularly slows down. Sometimes if you divert outside of your department to a co-located UTC, those children end up coming back, or a proportion of those children end up coming back, and how do you manage that ping-ponging? And then you also have to, I don't think this is, if you've not got an external UTC, you're unlikely to suddenly be able to build one in next to 4 to 6 weeks. And I can already see on the chat that there's a lot of discussion about that. So that's a lot of themes that I wanted to go to. Really sorry that my battery nearly died. But I'm just going to pause there because I've said a lot and I've done a lot of talking. I'm going to stop sharing my screen now because it just helps me see who is here. I just want to check. I've seen John Priddle, who I was going to ask, and Patrick Aldridge. Is he here?
Yeah, I'm here. I'm just on. Don't have my name on the thing. Sorry.
That's okay, no worries. Patrick, can I ask you first? I just for a couple of minutes. You've just had a head injury type stream and some other nurse-led discharge. I just wanted for you just to run through mainly that email you sent me about what's worked, what hasn't worked.
Yeah, sure. So we're at Frimley. We've got a few nurse-led pathways. The one that's probably functioning the best is a nurse-led head injury discharge process. Lots of other people on here probably have similar. Ours differs that it's band 5s that are ED triage competent, and we're sending home minor head injuries and kids with lacerations that just need glue. We're probably sending home about 20% of the kids, which is about 4 or 5 a day. Doesn't sound a lot, but some days there aren't any, some days there are. The reattendances from it is about, over a 9-month period that I had the energy to analyse it, was probably 3 or 4, some with wound infections, some with vomits, the kind of usual stuff. The thing Damien wanted me to discuss was more the challenges that we had with it. The biggest was probably governance. It probably took me about a year to get the governance for it. That's because there was no evidence for it really. Lots of places have done it, but there wasn't much evidence for it. A lot of other places, as I said, have these processes. I think if for helping for this winter, if you haven't started a governance process around this, you're probably not going to get it in before the spring, summer. With a good headwind, you're probably looking at 6 months at a guess. The other thing really was it's a big culture change. So we did it for band 5s, so PDD triage competent. A lot of other places have it for band 6s only, or some places even band 8s, band 7 to 8. So that was a big sort of culture shift and getting buy-in and belief. It is as Dame alluded to, some of this stuff is the low-hanging fruit that could be a quick turnaround, but it was changing that kind of the process. And then when we did the analysis, we thought at least 50% of the kids could go home like this, but actually it's only about 20% are going. Some of that's because some nursing staff are more comfortable with it. It's not you must send them home. It's if you're happy to send this home, we think this child is low risk. And so there are some nurses who are more comfortable with that than others, which is absolutely fair enough. One of the other challenges was wound closure. This is a triage nurse who is sort of doing this process, and so we changed it slightly to our HCAs close the wounds with glue. So they're competent. Other sites that might not be as easy to do. And probably the last point to make about the sort of head injury bit is that some of the feedback from the nurses has been, when we're really busy, like now, it's not as easy to do this process because it like everything, it takes time. They're having to give head injury advice, potentially close the wound, or ask someone else to close the wound. So on the face of it, it seems good, but sometimes when you're really busy, if you're the only triage nurse, you can't necessarily do it. You might be able to come back to them later, but it's not always sort of quick. Saying that, when we have 10 to 15 kids rock up all at once, it's really nice that within an hour, a lot of those kids have disappeared from that list. When you're sitting there looking at all these kids that are waiting, suddenly a couple of them have gone. It really is, as I describe it, it's the gift that keeps on giving. You train the nurses up to do it, and they, and when they can, they do that, and that's really advantageous. The only other thing probably to touch upon is we've got a nurse-led croup one that's still in its early days, and again, the same with the head injury one. It's getting the nurses signed off on their competencies and getting people who can sign them off. That can be a sort of rate limiting step for doing this. That's probably about all the comments.
Brilliant. Thank you very much. I can't remember if you've shared your guidance on the shared Google Drive that I put together, Patrick. If you haven't already, please ping them along, and I will send we have a similar system in Leicester. I will put those together, and then as the email I will send out as a result of this session, I will send that out to all sites, so at least you can have a look. I suspect those of you who are doing it already, it's already the same. If you're not doing it, it might be something that you can pick up. Okay, thanks for that. I'm just trying to kind of make sure I keep up with the chat. While I do that and come down with another list of questions to take back to people, John Criddle, I saw that you had your hand up, so you can ask whatever question. And then I've just asked John specifically, because I've had some really interesting conversations with John about some of their senior buy-in that he's got in his trust. And I just, John, just as a short reflection on kind of your trust and where you are.
Yeah, okay. Maybe if I could just, very quick question I had. So we've kind of struggled with the nurse triage discharge of minor head injuries and doing the wound repair as well. The big pushback we always get is the triage nurses are too busy, which they are, doing their initial nurse assessment and OBS, etc. And there's a real tension there. So I think it's really great to hear from a department where you've been able to implement this. And of course, we have a huge drive in our department to try and maintain efficient, fast initial assessment and at least getting a rapid sort tool OBS done on patients. And the pushback always in trying to get kind of rapid discharge with minor head injuries at the front door is we're too busy doing triage, and anything that slows us down, i.e. doing the head injury advice and repairing that wound, which only takes 5 minutes to sort out, is just going to cause the triage queue to build up. And there's a real tension there. And I think using the HCAs is a really good thing, and it's something that we've tried to develop as well. So it's just really good to hear departments where it's working.
Yeah, thanks, John. I'll collate some of that feedback. But you should just quickly about your
Sure.
kind of your senior team's involvement.
Yeah, I guess this is just slightly left of field, because I know what people actually want to hear about is operational stuff in the department, and what does good look like, and what things can we improve to try and keep the flow going, etc., etc. And I just kind of I had a reflection on the huge challenge that we're all facing and how hard and tough it is. But actually, how are we supported as a department within your clinical network and within your clinical environment? How well supported are you as a team coming into what could well be even harder times in November, December, when the weather gets really cold? And I actually feel incredibly well supported by my DMT, the Directorate Management team, and indeed the execs of the Children's Hospital and above. And I think it's really, really important that what does good look like for this, because it absolutely is key in I think making sure that you as a PEM lead is heard, and that your concerns are heard, and that you can work with your DMT to mitigate as much as you can to make sure that you have finessed your processes and your space and your environment and your staffing to the nth degree as well as you possibly can. And so I actually do feel really supported and feel that we do work incredibly well with the DMT and the execs of the Children's Hospital, and that they listen to us and that they work with us to try and put things in place to try and make things as good as they possibly can be. So what does good look like in terms of that? Well, I don't know. I've no idea what other people get in terms of this, but I think we're really lucky in that we have a meeting called Star Chamber, when we actually get to meet regularly with the directors for performance and for nursing, and the medical director for the Children's Hospital, and it's with a focus purely on PEDS-ED. How is it functioning? What's your plan? What's your development plan? And how can we, as the directorate and the executive team, how can we support you? And we have a conversation that's very open and transparent, and we are listened to. and we hear about how we fit into the rest of the children's hospital and the community and the network. And we have very real conversations about what they can do to support us. And that's been incredibly helpful going forward from the summertime, planning forward into the autumn, winter of how it's going to be. And I feel listened to. We've been able to put in and talk about cases for expanding the consultant team, expanding the nursing team, having extra nursing support for the triage and the front end, working with the trust to develop an urgent care offering for children, and support in terms of environment and being able to develop the estate, and making sure that this is seen as a priority for the trust, which it is. And then again, the more regular meetings with my DMT, the Directorate Management team, again, incredibly supportive working relationships where they will listen and help us move forward in terms of development and expanding the team and staffing appropriately. And yes, there are huge issues with nurse staffing, especially at the moment, in terms of being able to recruit and retain, and staff are kind of been through COVID and aren't doing as many bank shifts as they used to. But we have real good conversations about flexing staff across the teams and within the children's hospital and being able to get that support. And I just think as a PEM leadership group, it's really important to engage with your management team to be able to do some of this. And it would be kind of interesting to hear how well other teams are supported in terms of doing this.
Thanks, John. That was really useful. I did want everyone to hear that, because I suspect that isn't what everyone's actuality in a department, but I do think it shows what is possible. And I really see from the chat about the difference between being part of a children's hospital or not. Now, I get there are clearly some advantages about children's hospital, but that shouldn't change the state of play, that if you have the data to suggest that your department is at the worst it's ever been, why is your senior exec not responding to that? And one of the things I think I will probably take forward with RCPCH, RChem is how can they help trust realize these pressures and help you have those conversations? Because I know from personal conversations with a lot of heads of services in the smaller departments, you feel completely ignored and completely out of the way. And if there's anything that we could do as a collaborative to help that, I think we should. So thanks, John. I'm just scribbling down a few notes about stuff that's come up. There's been a bit of discussion about the kind of the redirection and not being able to redirect because the other services are overwhelmed. Certainly a lot of chat about the head injury pathways and how you get the staff to be able to deliver these things. Now, clearly, I think there's always going to be challenges with staff and finding the resources for those staff. One of the things perhaps that we could do as a group is those pathways where at least the assessment nurse decides it could be a nurse or HCA-led discharge, and then that patient goes in a separate stream for someone else to sort that out. Now, that requires someone else to sort them out, but it means that stream is different from the stream of being seen by a clinician. And I think that type of pathway might be useful to think about. And I think a few people have stuck in the chat that that's what they try and do. And I think it would be worth units trying to pull that together. One of the difficulties, though, is do you prioritize the most well patient, i.e. someone who's got a lack, against those who are really unwell? And I really do get that particular tension. Then there's a bit of chatter about senior members at the front door. It would be really useful. Is there anyone who's on this call who actively put a consultant or a senior registrar and front load them? I see, Kate, you've got your hand up. Is that to ask the question or to respond to that? Is that something that you do? Kate McKay, it's all yours.
Sorry, Damien. We've trialed this as a challenge, as a thing in the last week, to be honest. As in, let's throw a new thing at the challenge for the moment. And we've been putting a consultant, well, we literally, I've just left another meeting saying we should do it between 10 and 6. We don't have the staffing to do it any other time. We're trying to flex our consultant hours to cover the evening a bit more to be able to do this, because our challenge is that the nurses are falling apart and are just broken. I was sending people straight home from triage yesterday with all of what you're talking about, these lacks and everything else. And I think that if you put anyone more junior on, then they don't have the power or the thought process, as in the confidence is what really I mean, to be able to say, yes, just go home. I think some credibility comes from the fact that you're a consultant saying, yes, just go home. But I agree, our other problem is with so many, the juniors also need supporting in the back end to be able to deliver an efficient service. I just wondered if anyone else had done anything like it, or, you know, that sort of thing.
Okay.
I don't know. What's the answer? Damien, you told me you were going to give me the answers.
Yeah, no, I feel really bad now that that this session is clearly not going to save the world. I do think potentially knowing things that perhaps aren't worth investing a large amount of time and effort in. So I think your example is really useful. It's interesting from the chat that the consultant workload is already so great that it's difficult to front load that. So in fact, I think that's really useful to me, because I don't think it's then worth us going on and trying to pursue that as an avenue. We need to concentrate on the things that we can and do deliver on. And if it's not a positive outcome, but at least it's not a negative one. Okay, I see a few more hands coming up now. Just taking on board, I'm noting to myself things that I would like to take forward, which is specifically kind of around how do we help those departments which aren't people on agendas, and streamlining some of these pathways. Amutha, you've got your hand up, and then I'll come to Dan.
Hi, yeah, so I'm down in Whipps Cross in London, and something that's really helped us in the last week is, I've got a very junior workforce, is we just pick up the DIBs and wheezers directly from the queue, and the juniors just start on them straight away. So it's even before the nurses have triaged them. So that frees up our triage nurse, that starts our burst therapy, and they've already started on that journey, as opposed to waiting a little bit later. Even though the nurses do triage the wheezers first, I've taken that out of the equation and said, juniors, that's your next one. You pick them up. The HCA will come and do the OBS with you. So that's given the journey. It's made a big difference, because at the moment we're having 5 or 6 people having burst all at the same time. It becomes a responsibility for the juniors, and then the senior oversees them. So in some ways, we've kind of taken out the sick kids ourselves and missing the triage queue, and we're relying on the presenting complaint put in by reception to say what it is, basically. But I think that's helped us with the flow, especially when you get to 4 hours. Our bursts have been done and reviewed, and they are going out the door within those 4 hours.
Thanks. I mean, that sounds great. I see our problem would be is having the excess of clinical staff to get to those patients. But I presume if you start that early on in the day, that is something that can continue to happen. That's a great suggestion. Thank you. Dan.
Hi, Damien, and hello, everybody. I'll try and keep this brief and positive, because I'm a positive guy, but I'm feeling a bit less positive this week. I guess what I'm thinking, I wrote it, was going to put it in the chat, but it just looks like an essay, so I'll say it out loud. We definitely need to look at pathways and things to optimize efficiency and flow in our departments. And so for departments, for example, that are not using criteria-led discharge, there's an easy-ish win there. My worry, though, is that for some departments, like I'm working in a really lucky department that's had a lot of resource in recent years, I feel like we're sort of talking right now on this call, for me, about plugging holes in a boat when there's a tsunami coming. So I guess my question is, there's probably 2 work streams here, aren't there? One is about optimizing efficiency in the department. Sure, we definitely need to do that. The second thing, though, is, and the hard thing, which, Damien, you are helping us to do, so don't get me wrong, I mean, this call is part of this, is what can we do that is completely new this year in terms of lobbying for and advocating a very serious system shift in funding and resource and publicity for this? You know, I have a department with 14 clinical spaces. Yesterday morning, we had 17 patients waiting for a bed. So, you know, I'm really worried that, you know, putting a consultant at the front door is great, but that's not what we need right now. We need a bigger hospital, which we're not about to get, and fewer children coming to the department, which the CCG in my part of the Southwest is not about to do anything about. So I think there's probably, let's focus on gains and wins in ED for sure. But separate to this call, and Damien, our thanks all of us, I would say, on the Leeds group for your work on this, is to really escalate this to the most senior level in the land, to say, look, there is a serious problem here. You know, I saw some stuff in the chat. Even in my trust, there's lots of, yeah, but it's worse in adults. Yeah, but children didn't vote for the government. You know, children are being biased and prejudiced against because they are children, but they also do not deserve at 17 days of age to be waiting for 23 hours in an emergency department. And I know we all feel passionately about that, and we're all feeling a bit tired right now and a bit stressed about that, but I think it's important that we keep that focus on that as well. So no suggestions from them, sorry. Okay. Just a comment.
So Dan, I did ask you, so hopefully you've had a bit of prep. There's given your experience with wellbeing, what is one thing that the department could do from a wellbeing sense? Just a small initiative. You've got no more than a minute to suggest it.
Yeah, well, I mean, yeah, it's a much bigger thing than a minute. Obviously, I can tell you what we're doing is that the consultant team and the senior nursing team are personally in face-to-face pulling staff aside every day and asking them how they are really and what can they do. Because our staff, as many of you I'm sure experience, are basically just leaving their shifts in tears at the moment. And that's a department that prides itself on a fantastic wellbeing program and all that kind of stuff. But, you know, we all acknowledge that pizza doesn't cut it at this point. And when we're nurses down and when the pressures are heavy, then that's serious. So the wellbeing initiative we've got up and running, like most acutely, is literally just face-to-face human contact off the shop floor with everybody in the department. And we're sort of prioritizing that at the moment. It's like back to basics, all hands to the pump stuff about looking after each other.
Brilliant. Okay, thanks, Dan. That's really useful. And I suppose to provide a bit of context, that the heads of service kind of PAM group is trying to get something down in writing that encapsulates some of the concerns. And one of the reasons I really wanted to have this meeting is to have that first-hand evidence. And I think you've encapsulated that well, Dan, of how everyone is feeling. And I do get the adult pediatric tension, but as Dan has eloquently described, children don't come to the emergency department, they are brought. And that is a significant difference from a lot of the adult world. And I don't want to diminish the extreme pressure that my adult colleagues are under, but we do need a vision that improves that quality of care for children. Okay, so covered quite a bit. I've also noted, so just written down a question about 111. So there is a lot of work going on 111. I know it feels like 111 literally send everyone to us. Part of the reason it feels like that is exactly the same reason it feels like primary care leach to us, is that once a system becomes overwhelmed, the 111 capacity to answer calls in a timely fashion becomes completely deranged. When you do get through, the advice has to take a certain level of risk. So if you have 100 patients phoning in a day about a relatively simple condition, it's likely that a couple of them are going to be referred on to us. And I know that there's a lot of people working really hard to try and improve the 111 offer, but those things aren't going to improve quite quickly. Part of that does involve kind of the use of extra pediatric staff, but again, that's involving a massive workforce, and I don't think that that's going to happen particularly for this winter. But rest assured, people are aware of how 111 moves through to us, and we are trying to do things about that. Okay, I think, and then we've covered senior members, we've covered, and then, sorry, waiting rooms. Yeah, so people have talked about the problem is that you're only allowed a certain amount of people. You have to split between blue and red. So this is personally, I I don't think we can tolerate this any longer, and I get why the IP advice exists, but we are going to be writing specifically to the RCPCH for their involvement in how we can have a reasonable agreement with IP about what and what we can't do. In 2018 and 2019, we just let broncholytics sit in a waiting room passing germs between each other. I know we shouldn't have done that, and I know that's not ideal, but we let it happen because that's the safest thing to do to manage a crowded waiting room. And I think we have to go back to some of those principles now. Okay, so yeah, and I think someone's put IPC agreement to no longer split red and blue. We've done the same. It would be good to share those documents. Okay, and then a bit of discussion about rapid access clinic. Julia, if you're on the call, did you want to talk quickly about how you've used rapid access clinics? That might be useful for people to confirm, deny.
Hi, Damien. Thank you. I think a lot of people do run clinics. I've just put in the chat that ours have just dropped recently. Well, this week, in fact, because we've had to switch the winter rota a month early, which we put in place last year. So we're now working through till 1 in the morning. I think you work till 2 in the morning in Leicester, don't you? So obviously the knock-on effect to that is daytime cover for seniors. So we've got less clinics. But the way our clinics are set up, we've got the 2 appointments. First thing are for rapid access appointments, and they are 30-minute slots. We then have 3 follow-up face-to-face slots, and then 4 to 5 telephone follow-ups. And the telephone follow-ups, I have to say, I think we're doing increasing numbers of those. And when COVID hit, we rearranged our clinics completely. So that's how we set them up. They work well. They prevent people from coming back into the main department. The downside being that you have to provide a consultant to run the clinics.
Excellent. Thank you, Julia. So do those clinics come from you basically take an allocation of your PA, which rather than spending on the shop floor is actually in the clinic? And is that just the PEM consultants, or is that all paediatric consultants?
No, that's just the PEM consultants, Damien. We have 6 of us doing the clinics, 5 actually, because I don't do it as clinical lead. And they're rostered on instead of being in the shop floor, but obviously that means we have to prioritise covering the shop floor. When we have a grid trainee, we do encourage them to take part in those clinics, and sometimes we run increased clinics, or we have the registrar doing the clinic, and then we're there available. They do work. We've got evidence to say that, but obviously they are labour intensive from the point of view of the consultants.
But what's the most common conditions you see there? It's just one of the questions in the chat.
So that's a piece of work I've asked my colleague Ian Lewins to look at as part of the SDEC work with NHS England, that I think you're part of as well, Damien, with Ian McConaughey. Yeah. So general, off the top of my head, I would say quite a lot of screaming babies for various different reasons. This child had a lymph node for several months. We have headaches, abdominal pain, but it's very hard because we take the calls directly from the GP. It's very hard to sift the wood from the trees, because a lot of these patients are waiting for a general paediatric appointment, which has been forever moved onwards and onwards and onwards, and then there becomes a crisis point that they have to have a rapid access appointment. So it's very hard to sort them through, but we're trying to get that data for SDEC. Brilliant.
Thanks, Julia. Now, I know time is against us. There's just one group that I just wanted to hit. Bimal, I know you're on the call, and I know, have to acknowledge that I suppose between us, Birmingham, and you guys, we're on a different scale. But something about what you've managed to do with getting pharmacists or other groups involved to redirect to. Is that something you'd just be willing to speak to just for a couple of minutes?
Yeah, sure. I'm hoping everyone can hear me. I'm just on my phone, so struggling to keep up to date with all the chat and stuff. So we've had a variety of redirects that have worked variously, because all parts of the system are under under pressure. So some of our walk-in centres have kept open slots for us so that we can redirect back out, because we're not co-located with an urgent treatment centre or walk-in centre. And that's worked variously, but it can be hard, as Damien says, it can be hard to redirect once the families have already turned up. The options that we've been able to put in that remain on site have worked best for us. So our pharmacy sourced some pharmacists for us who are trained up in clinical assessment, and so we have them working alongside us in the pharmacy along a well-defined list of minor ailments that we can redirect to, and when that works, it is great. They'll take a lot of that low-hanging fruit off, and a lot of the things. It was a big learning curve for our nurses, because actually they wouldn't direct a lot, and then when the consultants or the senior staff would come along and go, actually, let's try this one, let's try this one, let's try this one. They were going to the pharmacist and not coming back, and we've not had returns back off those patients, just on a quick scan. So that's worked well and is improving the more we use it. Another thing that worked really well for us is our health visiting team service source health visitors for us 7 days a week during the days, and we would then, from triage, a lot of the babies that take a lot of time, mum's worried about feeding, they're vomiting, they're just crying, they're unsettled, we would stream to the health visitors who just gave them the advice that they were looking for, and were able to satisfactorily for the families address their concerns without then needing a further medical follow-up or further assessment, because we know these are exactly the sorts of babies that take our less experienced staff a lot of time to assess and work through and possibly over-investigate. So that's something that we'd be looking to build on more consistently as well, and potentially keep for when the surge is over and it's a brighter day, because that's a large proportion of our type of attendances. Crisis team as well. Our crisis team have started to take direct calls from families who aren't known to them. This is for CAMS as well, and started to do some of that initial assessment and triage as well for those that aren't intentional overdoses. So those are some of the redirects that have worked well for us.
Brilliant. Thanks, Bimal. That's really useful. And I mean, I do think some of the things about health visitors and pharmacists are, regardless of the size of the unit, that they are conversations that you might be able to have with their commissioners, because they may be a particular kind of route to care. It's not going to be game changing, but at least it's something that you can ask for. Okay, so there's only a couple of minutes left. There's been quite a long conversation about kind of point of care tests and the pros and cons. So the advantage of being able to know someone is COVID negative so that they can go to a ward and don't take up a cubicle, versus the time it takes to do that test, who does that test, and actually what happens if they are positive, because my concern is all these patients then get trapped in the emergency department. I might need to take a bit of time to read through that thread afterwards and maybe draw together some strands that we can take forward. I appreciate there's a large group here. Is there anything else that people wanted to highlight or say, especially stuff that I've missed? I was deliberate about this being an hour, because I think we all are time pressured, and when you go beyond an hour, it just becomes difficult to kind of maintain enthusiasm. I know that we're going to pick this, Jane is going to pick this up from an APEM point of view, and we may just run another one of these events in a couple of weeks' time, just to pick up the things that we've not been able to cover. But Moya, okay, mental health issues, yeah, so kind of Bimal alluded to that, but we've not picked that up. Moya, is there something you wanted to specifically say, something that you've done or something that we need to look at?
So we, like everyone, I'm sure across the board, has had a big increase in attendance of teenagers with mental health crises and difficulties. And what we're experiencing is that when they're discharged from a medical point of view and they're fit for discharge, they're not fit for discharge from a social or mental health point of view. And we have had some children stay in the department for up to 67 hours in the emergency department. And we're really trying to work out strategies whereby we can work with social services and CAMHS to discharge these patients within a reasonable time, and we're really struggling. And I was just wondering whether any other trust, across the country today had any other strategies whereby we could discharge these patients sooner rather than having a terrible time. One child, we had to actually shut half the department because she was so disruptive, and we can't do that with the number of kids that we're seeing here in Oxford. So it was really just to open that to the floor to ask what other people's strategies were, which may not be suitable for 1 minute left for the meeting, so apologies.
No, I mean, I think that's a really good challenge, and I think that we may need to think about something specifically about mental health. We are fortunate as well to have an all-age mental health team who see most of our patients kind of directly, the ones that are easy to discharge, but we have similar problems with some patients who exhibit a number of challenging behaviours, which may not be even the child's fault, but causes massive disruption for the department. And our mental health services are completely overwhelmed. So it's the same situation as having a sick bronchiolitic who can't go to PICU or HDU because they're full and this child needs respiratory support. We have the same issue. These child need mental health PICU and their PICUs are full. And I've got no easy answers for that, but kind of sharing resources of things that people have worked might be a good thing to do. Cool. Okay, I think we've come to an end. I've also noted a chat about supporting nursing colleagues. I invited nurses along to this meeting. I know it's been a bit kind of medically focused with the people that I've asked to speak. Perhaps that we could address that in a future meeting specifically with kind of nursing leaders. And I'd be very happy to help facilitate that as well. Again, I'm really sorry, I've not got any answers that particularly solve the problems. My main purpose of doing this was, one, to make sure that I was on the right page, that everyone is kind of feeling the pinch, which I think they are, is to share those things that maybe people haven't picked up, which I think we've tried to do in the chat. And when I send the email via Eventbrite to all people who are registered, I will put the link again to a Google Drive that exists of people's pro formas. And that we will keep this conversation going over the next couple of weeks and months, either through just maybe repeating this session again with some specific themes, or being able to share kind of learning that emerges over the next couple of weeks. I will be taking a particular document to the RCPCH to highlight some of the concerns that directly come out of this meeting, to look at whether we can address some of these things at a national scale. But thank you very much for your time. If there was something that I've missed off completely, please do try and just stick it in the messages, and I will pick that up at a future meeting. But please keep well, everybody. It is really tough out there at the moment, and make sure that you've always got someone to talk to or go to if you run into individual concerns, or that you know people who are. Thanks a lot.